Nowadays, I think what we really clearly know is that we just treated the wrong patient population. Because, as I said, we know now very precisely that the pathology starts already 20 or 30 years before you see any clinical symptom. And that is important because the patient itself will also never realize this. So there's one very good criteria, there's even a scientific publication about this, that you don't have Alzheimer's disease if you come to the memory clinic and say you have Alzheimer's disease. Because normally it's the relatives that have to force the patient to go and get testing and things like this. But this is the point. And now there have been actually 3 trials that were kind of successful with the antibodies. So aducanumab was the first, lecanemab and donidalorsen is now there. And why are they now showing first signs of the fact that actually you can have a beneficial effect with an anti-amyloid therapy? Well, because the companies that run these trials now put a lot of effort and money into patient stratification. So now in these trials, which show first signs of being successful, actually you treated people who really are very, very early, and they confirmed by imaging approaches, by functional imaging, for example. You can look with a MRI scanner and see, do these people really have plaques and amyloid building up? And only these people who clearly have this and are very, very early in the pathology are now included and get this therapy. And then all of a sudden you see, yes, first of all, something that we always saw, the plaques are gone. So this always worked. So in a way, in the patients, you always saw what the animal model was showing you. So the animal models are all really good. But there was no improvement in cognitive function. And now, I mean, it's also not super dramatic and significant. And it's debatable what it means if you increase by a few points on a scale. Because in the end, the question is, can the patient lead a life rather independently or not? And not if it increases 3 points on the cognitive score. But there are good signs, actually, that these things work. And that is because you not only remove this amyloid, but you do it really, really early. And that's what you need for a causative therapy. So if 50% of the cells are already dead, you can remove as much amyloid as you want. You will never see an effect. So the amyloid is gone, but there's no improvement in cognition. So this is why, in addition to the therapies that most likely do work as they should, as we know now, and they are already approved, we need to have ways to identify these people really, really early. Now the question is, how do you do this, right? And of course, you cannot do in practice then what they did in the clinical trials, so that you spend millions of euros to screen everybody above 50 with an MRI, PET scan, and CSF taken and all this stuff every other year. So this is why the field is now really moving to have markers that you can use at the population level for screening. And then you need liquid biopsies, but you don't want to have your cerebral spinal fluid. Actually, you want to have blood. And there is a lot of effort and also very promising data that at least what looks now, so when in your brain amyloid is building up, in the cerebral spinal fluid and in the blood, it goes down because it builds up in the brain. And this now you can very reliably measure in the blood, this drop of amyloid, for example. And that correlates well, has been shown with the MRI. So the idea is actually that you don't have to put everybody into a brain scanner, but you can first do a blood test, which would be, of course, much cheaper, much easier, and super fast to be done. And also that doesn't need much of an infrastructure, right? So this is one thing that people go about, and then there's great hope that actually when this will be available and you start with the therapies really early, that this would be super beneficial. Now, what is now on the market are these 3 different antibodies against amyloid, which seem to work very well. The question is this now something that you want to give on the long run? Because it's also super complicated, and it comes with some really severe side effects. So if you give these drugs, probably every 2 months, people have to monitor it by MRI so that they don't get any microhemorrhages or bleeding in their brain. So that's also not so easy. But there are ideas now that maybe you don't have to do this all the time. It's rather the strategy, if you identify people early, you give them, for example, an amyloid treatment with an antibody, but you give it just as long as the amyloid is cleared from the brain. And then you stop, and then you give some other drugs, some maintenance therapies that, keep the status for a while. And then maybe in 5 years you have to do it again, something like this. And in addition, of course, you still need other therapeutic approaches that help to just increase the learning ability and plasticity. And this is something where we are working on now, in addition to finding biomarkers, to give, for example, epigenetic drugs, which are known to be key regulators of cognitive function. And if you inhibit certain molecules there at the epigenetic level, you can clearly see that there's a cognitive enhancement effect. So something like, a pill that would mimic the exercise effect that we just talked about, for example. So this is where the field is now going, and there are a million of other approaches. People also try to knock down tau with so-called antisense oligos and things like this. There are other therapies, anti-inflammatory therapies. I mean, everything that worked in animal models but never worked in humans, for the very same reason that I just talked about with the amyloid. At the time point when the patient nowadays is diagnosed, it's too late. Because also epidemiologically, there's a clear correlation. People taking anti-inflammatory drugs for whatever reason, rheumatoid arthritis or something like this, they have a lower risk to get Alzheimer's disease, or cholesterol, actually, drugs that decrease cholesterol, for example. They also work, but of course not as a drug when you give them when the patient is already sick. So the future is actually markers for early detection and then combinational therapies. So probably we also go away from the fact that there's just one drug that has to be given. Most likely it's be a combination, maybe not all at the same time, but at different time points that will be combined. And for the early detection, I think there is this idea that there would be something like a dementia compass or something like this, where you have a set of 10 different tests, blood-based biomarkers, maybe some digital health apps, for example, where you can test your cognition, that people just randomly are offered to do once they are 50, and they can then screen their cognitive reserve, so to say, and then, when 3 of these 10 tests actually get down, then you get a message, okay, go to the memory clinic and have you checked up, and then they can decide if you have to get a brain scan or a more sophisticated blood test of amyloid, so that you have these people early, like they do in cancer screening programs, for example, which have been very successful.
Do you know how expensive are these treatment with these antibodies?
It goes about 20,000 euros, something like this.
Per pill, or?
No, that's not per pill. I think that's so 20 to 40,000 is per year. So that is expensive, but it's also not much more expensive than the antibodies for cancer treatment and things like this.
That's good to know. I did not know that we have this kind of success. I heard about these drugs. I think even during one of your lectures 2 years ago, there was the trial with aducanumab.
Yes.
And I did not know that there is some kind of a success if you introduce the drug in the early stage.
Yeah, the latest drug now showed actually that all of them are very similar in clearing the amyloid out of the brain. But the latest antibody now showed even that there's an improvement in certain cognitive domains, about 30%. Or let's say not improvement, so it slows down the progression, right?
This is the thing, that we now try to slow down the progression. We cannot stop it. We don't know how to stop it. The only thing is to detect it early and try to slow it down. Right?
Exactly. And there are other preventive strategies. So the key would be really actually to build up your cognitive reserve while you can still do it, and then start any of the therapies early. And I think now, this is not the final cure now, but I think it's a very nice proof of concept. Because, there was always this huge debates also when I started in the field. So there was either tau, there was amyloid, and they were not liking each other very much, to be honest. And then if you were doing something different, like epigenetics, people were laughing about you, right? What does this has to do now?
Neuroscience and beyond. Know more. Get inspired.